Okay. All right. Well, today we're going to talk about, I don't know what the schedule said. Again, I'm Dr. Oehler. Today we're going to talk about intravascular catheter-related infections. This is a topic that doesn't get a lot of treatment because it's very complicated, and this is a brand new lecture, so I hope I do it justice here. We'll have an opportunity for discussion and for questions and so forth, but bear with me here. I think I'll answer a lot of your questions about how to treat catheter-associated bloodstream infections. So, first of all, why do intravascular catheter-related infections matter? Well, there's some 250,000 cases annually in the U.S. each year. About 80,000 of those, I guess that's roughly about 30 to 35%, are associated with patients in the intensive care unit. Probably most of you are thinking that's fewer intravascular infections than you might otherwise think. After all, a lot of our intravascular catheter use is in the intensive care unit. But as we're seeing increasingly, intravascular catheters are used in the outpatient setting. We get more patients going home on antibiotics. We get more patients who need PICC lines when they're out of the intensive care unit as well. This is a major cause of morbidity and mortality, and it's an active area of infection prevention. When we talk about implanted venous catheters, we can roughly differentiate them in terms of short-term catheters and long-term catheters. So these are short-term catheters that you may all be familiar with. Peripheral IVs, again, tend to be used for short-term, 5 days or less. Midline catheters are often implemented when we need something that's a little bit more reliable to use and longer and can be placed in for longer. However, there are certainly shortcomings with midline catheters as opposed to PICC lines, which are similar but longer in terms of what can be infused and perhaps even in terms of infection rates. Triple lumen catheters seem to be used less these days because of the advent of PICC lines, but they tend to have higher rates of infection. Now, these are long-term implanted venous catheters from the PICC line, for example, which all of us are at this point very familiar with. And then we talk about catheters that are tunneled or implanted. A Hickman catheter is one such example. They go by different names from Grishon catheter to Hickman to Broviac and so forth. Then you have your implantable ports. They also go by the term of portacath, or there's a variety of different names that are associated with implanted ports. We see these a lot in patients who are immunocompromised, let's say at our sister institution across the street, where patients need long-term access for the administration of chemotherapy and blood products and so forth. So what are some further epidemiologic issues or information regarding intravascular catheter-related infections? There's been some success in general across the U.S. in reducing the incidence in the ICU in the last decade, and some of this may, there's a variety of different reasons, let me put it at that. And as we said earlier, this is just not a phenomenon of the intensive care unit. There were 23,000 cases per year of related infections not in the ICU in 2009, for example. And in the SCOPE database, which is the national database useful for looking at preventable infections and for surveillance, 51% of these catheter-related infections were in the ICU, and 49 were outside of the ICU. And among the different types of catheters, triple lumen catheters or central venous catheters have the highest rate of infection, followed by PICC lines, for example, about 35%. Arterial lines, let's not forget them. They are also a source of intravascular catheter-related infections, and they were about 16% of cases. Mean incubation period of 12 to 26 days. Of course, that's dependent on the pathogen. And crude mortality about 27%. Again, we don't often think about intravascular catheter infections automatically causing severe morbidity, but almost everyone in the room here has recalled a patient who developed a severe bacteremia related to an intravascular catheter, had severe morbidity or even mortality related to that infection. These are major infections, as Dr. Tony and Dr. Gompf here will tell you, in terms of expenditure of resources and patient stay. They have a major impact on the hospital. So what are some special groups that we need to consider when we talk about intravascular catheter-related infections? Well, hemodialysis patients. We know that these patients, when they're waiting to get something that's more permanent, will often have implanted catheters. And these implanted catheters, although they're in many cases, they're placed for short-term use, a lot of times in many patients will remain in for an extended period of time. They are very susceptible to infection. In addition, hemodialysis patients tend to have varying degrees of immunocompromised status related to their renal disease, and they may be more susceptible. We see a lot of gram-positive infections, a lot of resistant infections in these patients. Burn patients obviously have alterations in their skin barrier, and also because of their burns, they may be more susceptible to certain types of infections like gram-negative Pseudomonas infections, which can cause catheter-related infections. TPN patients are more susceptible because of the type of infusate that they receive. So what types of infections do TPN patients tend to get? Fungal or candidal infections, right? Now, when we think about oncology patients, we can't all lump them together. They may, we have to consider subcategories of the neutropenic patient, patients who have stem cell transplants, patients who have solid organ transplants, and then the severely immunocompromised. So think about all those classifications of intravascular catheter-related infections that fall under the oncology patient, quote unquote. And then we can look at risk factors. So chronic illness certainly causes impairment of the immune system and can also make patients need long-term intravascular access. Stem cell transplantation, again, requires long-term access with patients who are very immunocompromised. Talking about the whole concept of immunodeficiency when it relates to nosocomial bloodstream infections, patients who have neutropenia where their AGC is less than 100, those are at higher risk. And there's a greater preponderance of bloodstream infections, catheter-related infections among those with hematologic tumors more so than those with solid tumors. And this is oftentimes because of the severity of and the prolonged status of their neutropenia. Patients with malnutrition often require intravascular access for nutritional supplementation, and that access may be long-term. Prior bloodstream infection will increase your risk. Extremes of age, and also, as we said earlier, those who have compromised skin integrity, not just because of burns, but think about the other patients who may have Stevens-Johnson syndrome, toxic epidermal necrolysis, or other conditions. So I think the title is cut off here, but catheter-related factors for bloodstream infection. Some other things to consider. The duration of catheterization. Again, if you have a dialysis catheter for a week, for short-term dialysis, you're obviously at lower risk than if you have it for months. That's self-evident. The type of catheter material is another thing to consider. Conditions for insertion. Was a catheter placed very abruptly in a patient who developed a cardiac arrest, let's say in the femoral area, versus someone who has a very sterilely implanted PICC line, for example, where maximum barrier precautions were used. So there's differences in risk factors for infection there. How good is the catheter site care? Is this a well-cared catheter site where the dressings are changed frequently, or is it a situation where maybe that care is not being used? What is the experience of the implanter? That makes a difference as well. So this diagram shows all the different ways that microbial pathogens can affect a catheter. So first of all, if you look there on the bottom left, we know that microbes can affect a catheter hematogenously. They can seed the catheter from distant infection sites. We see that in patients, for example, who may have a cellulitis and they have a catheter in place. They get a bacteremia with Staph aureus, and then hematogenously the catheter is at risk for infection. Those microbes sort of extraluminally can adhere to the fibrin sheath or thrombus and develop a biofilm, and the biofilm can protect the organisms and can make treatment of the infection difficult if the catheter is retained. Now, you can also have migration of organisms from the skin, for example, extraluminally down and through the insertion site and along the exterior of the catheter, and that occurs at the catheter entry site, as we see there in the middle of the diagram. Now, you can also have infection from the catheter hubs as well. Microbes can migrate interluminally from colonized hubs. That can be affected a lot by how the hubs are cared for and handled. And lastly, you can also have infection of the catheter from the infusate. If you have contaminated infusate, that goes directly into the catheter, and that can affect the catheter intraluminally. So the hubs and the infusate are ways that intraluminally infection can affect the catheter. So let's play sort of a mental exercise here, and I'm going to ask you all, and you can shout out which of these have the highest risk factors for infection. So let's talk about site. Which has a higher risk of infection? Femoral, internal jugular, or subclavian? Femoral. And that would be followed by what? Internal jugular, and lastly subclavian. That is correct, right? How about use? Which has the highest risk factors? Antibiotics, hemodialysis, or hyperalimentation? Hyperalimentation, everyone is saying. What would be second? Hemodialysis. And last would be antibiotics. Okay. I'm not sure about the first two. Certainly, I think all of us would recognize that antibiotics would have the lowest risk. Certain antibiotics more so than others. But many of you are saying that hemodialysis has a lower risk than hyperalimentation. My answer to that is I don't know. I see some shaking heads in the room. How about barrier precautions? Does submaximal barrier precautions, does that have a higher risk factor than maximal barrier precautions when you're placing a line? I think everyone recognizes that when you place a line, you should use maximum barrier precautions. That just goes without saying. And nowadays, the idea that any experienced catheter placer would use anything less than maximum barrier precautions, namely a sterile gown, a cap, booties, if you will, even, and sterile gloves to place a catheter. I think it's becoming more and more accepted among catheter placers that is something that you do not do without. How about insertion? Are tunneled catheters versus non-tunneled catheters? Which one has the highest risk? Non-tunneled, right? So it's accepted that when you tunnel a catheter, you introduce an additional barrier to microorganisms getting into the catheter site and we're talking about extraluminally, that will prevent infection. Non-tunneled catheters have a higher risk of infection. We've said that, right? For example, the risk of infection from a peripheral IV, we would acknowledge, or an art line would be higher than, let's say, a Hickman catheter, which is tunnel. Now, how about coating? Bare catheters versus coated catheters. We're talking about antiseptic coatings applied to certain catheters that have an antimicrobial effect, particularly extraluminally, perhaps intraluminally, that inhibit infection. Which would have the highest risk? Which one? Bare? Controversial. That's the bottom point. Okay, what are some other risk factors for infection? Catheter thrombosis. If you have a catheter where there's a associated thrombosis, obviously a higher risk for infection. Repeated catheterization, especially changing lines through the same in the same location over a wire, higher risk of infection. Right? You introduce trauma into the site. When you put another catheter in through over a wire, you're basically you can argue if the site isn't adequately prepped, you're introducing organisms into that tract. Similarly, as you would if you catheterize a patient through the urethra, self-catheterize, theoretically you can introduce organisms. Distant septic foci. If you place a catheter in when a patient has an active infection, let's say a cellulitis or an endocarditis, is there a risk that there's a bacteremia going on? And when you place the catheter, you're doing it under higher risk of infection. So what are some sources of infection? Skin colonization, right? That's why we prep an area when a catheter is placed. The idea that anytime you introduce a device through the skin, you have the potential for introducing infection into the object you're placing through the skin. So some people, more than others, may have heavy skin colonization. Some sites may have more heavy skin colonization, and this can induce infection. We know that, as we said before, bacteria can migrate along the subcutaneous tract into the fibrin sheath surrounding the catheter and can introduce an infection. So biofilm plays a very important role, and many of these organisms are obviously skin commensals, like Staph aureus, like strep, like coagulase negative staph as well. Intraluminal contamination tends to be more of a factor in surgically implanted devices, and we know that because when you tunnel a catheter, you reduce the risk of extraluminal infection, right? Because there's an added barrier, there's more distance between the intravascular site and where the catheter exits the skin. Also, certain catheters that are cuffed, that cuff around the catheter tends to provide a barrier. Hematogenous seeding, as I said, usually related to a bloodstream infection from a distant focus. And we talked about infusate contamination. That can be through handling, manufacture, solution prep, or sometimes bacteria can reflux into the catheter bag in preparation of that bag. When we talk about microbiology, this is based again on the SCOPE database. What are the most predominant organisms? What are the least predominant? Well, according to the SCOPE database, the most predominant cause of intravascular catheter-related infections is coag-negative staph followed by Staph aureus. Now that's intuitive to us, right? Because those are skin commensals and it's easy for them to cause infections. Number 3 would be Enterococci, followed by Candida. Both are at 9%. And then from there you have enteric bacteria, Pseudomonas, Enterobacter, Serratia, and Acinetobacter. So if you take the top 4 there, it's easy to remember, right? You have your staph, you have your Enterococci, and you have your Candida. So really, when you think about catheter-associated bloodstream infections, if you guess one of those 4, you're going to be right about 70% of the time. What are some other considerations as far as other organisms? Think about Stenotrophomonas in oncology patients who are subject to broad-spectrum antibiotics like carbapenems, where you get overgrowth of resistant organisms. Bacillus, Corynebacterium JK, are occasional pathogens in certain settings, and you have to take them seriously. When catheter infections involve multi-drug resistant gram-negative bacilli, you have the additional risk of treatment failure and death because of endotoxemia and because of the resistant nature of the organisms and the fact that they may require specialized therapy that you may not cover. Glucose-rich infused solutions like hyperал, again, remember we think about certain species of Candida like Candida parapsilosis. You can have polymicrobial infections, that's within the realm of possibility. Anaerobic organisms rarely produce catheter-related bloodstream infections, so we don't often cover for those. We talked about Pseudomonas and burn patients. And we talked about in cancer patients, particularly hematologic malignancies, they're prone to enteric pathogens and gram-negative bacilli because of the ablative effects of chemotherapy. So let's go to a clinical history, and we can all think about how to manage this particular case. 56-year-old male patient with pancreatic cancer, status post-Whipple procedure, has a PICC line placed in the right antecubital fossa on January 15th and is started on TPN. 5 days later, he develops a fever of 102.5 and you are consulted. You see him and you notice that he has a moderately swollen right upper extremity. White blood cell count is 15,000 and he is hemodynamically stable in the SICU. So appropriate next intervention. So what would you do to this patient? And I'm going to call on Dr. V in the back to tell us what you would do.
From those options, I would immediately obtain blood culture.
Yes, very good.
Also a Doppler of the right upper extremity because of the swelling. You want to make sure there's not a clot that complicates the bacteremia as well, or in addition, causing the fever. Once you have your blood cultures, then sure you can start empiric coverage. And depending on what you find at that point, then you make the rest of your decisions because you don't necessarily find it.
So for those of you listening at home, not a problem. We would obtain blood cultures. We would Doppler the right upper extremity and start empiric antimicrobial coverage. Remember, after blood cultures are obtained. The last two there I put are a little more controversial. Do you remove the line? That's sort of an issue in itself. And when do you order additional studies to rule out, for example, a septic focus or a complicated line-related infection? So we agree on the first three. The last two are sort of qualified. So you obtain blood cultures, you write the order for a right upper extremity Doppler, and you plan to start empiric antibiotics for presumed catheter-associated bloodstream infection. Antibiotic therapy should include coverage for which of the following broad categories of organisms? Gram-positive cocci, yeast, gram-negative bacilli, or anaerobes. And Dr. N in the back, I'm going to call on you. What would you start this patient on? So gram-positive cocci. Okay, any other coverage? Okay. Would anyone add anything else?
The risk factor with the TPN is a concern for Candida.
So you would also add B as well. You'd add coverage for B, right? And I think that would be the correct answer in this case. Remember that this patient is status post-Whipple procedure and is on TPN, so is a risk factor for fungi as well, for Candida. And because of the GI surgery, there's a possibility of gram-negative bacilli involved. Because it's a line infection, you have to think about gram-positive. So probably A, B, and C I would do here. As we established before, anaerobes are not usually a cause of a line-related infection, so you don't often cover for those. Very good. So let's move on here to our diagnostic workup. And what are some basic principles? Well, first we want to clinically assess the patient. We want to think about what microbiologic organisms are involved. And we can do this by obviously culturing the patient. And when we think about the workup for catheter-related bloodstream infections, we consider culturing the patient's blood, which is kind of a surrogate marker for a catheter infection, if there's a bloodstream infection. And then we think about culturing the device as well, right? So we assess the blood and the catheter. So clinically speaking, suspect a catheter-related bloodstream infection in a patient who develops a fever or positive blood cultures, right? And they happen to have an implanted catheter. And when there's not an apparent source. Obviously, if you have a patient with a cellulitis, a severe cellulitis, and they grow strep pyogenes or they grow Staph aureus, then you have an obvious source, right? Even in the setting of a freshly implanted catheter, you'd be less likely to think about a catheter-related bloodstream infection as opposed to someone who had an implanted line with local erythema. The line's been in for a month, and they have positive blood cultures, they have a fever. That patient's much more likely to have malign as a source, right? So those are kind of two areas of the spectrum. You also want to consider a catheter-related bloodstream infection if in someone with inflammation or purulence at the insertion site, someone who's hemodynamically unstable or their mentation is altered, if their catheter can't be used because it's clotted, or if they have to put thrombolytics in the catheter, if they develop sepsis after infusion, let's say, for example, their bag of TPN and they suddenly become unstable, that may be somebody with contaminated infusate. Patients with bloodstream complications, thrombophlebitis, endocarditis, osteomyelitis, metastatic infection. Now, how about getting blood cultures? It's critical to obtain paired blood samples from the catheter and a peripheral vein. And sometimes a complication of this is when your particular hospital doesn't label the blood cultures. How do you know which came from the catheter? How do you know which came from the peripheral vein? You generally want to use the same volume of blood for each, and if possible, you want to label the bottles. Labeling the bottles is crucial, but it's often something, it seems like it's very difficult for the phlebotomist to do in every case. The highest organism correlation when you have positive blood cultures, remember, is with those top four organisms, more specifically Staph aureus, Coagulase negative staph, and Candida species. When you talk about Enterococcus, a lot of times because that's an enteric organism, there can be some confusion about bacteremias. But in general, those three tend to correlate with a bloodstream infection. Catheter cultures, isolated positive blood cultures from the catheter, tend to have a higher false positive rate than peripheral cultures. Now, why is that? Why is that, Pam? Right, because you may actually be culturing out bacteria that came from the catheter, and obviously the false positive rate of that is higher than if you have somebody with, for instance, a positive blood culture from a peripheral site, and it correlates even higher if you have somebody with a positive blood culture from a peripheral site and from the catheter, and they're the same culture. Obviously, there you have, that tends to have the highest correlation. Both types of cultures have excellent negative predictive values, so if the blood cultures are negative, again, that's very significant, right? And if you have a dedicated phlebotomy team who's experienced and they do things per protocol the same way, obviously you can reduce your blood culture contamination rates. Can't you, Dr. T there sitting in the front?
Yes, and the skin prep is...
And the skin prep is very important.
Absolutely crucial. The other thing is, when you talk about it, remember we use needleless systems, and if you don't do adequate prep on the hub, you're more likely to get contamination. And they have these nice little clean cap things that have high concentrations of alcohol in it. You try and clean the hub that way, allow it to dry, and then sample through it. Dramatically can decrease the rates of contaminated blood culture.
So, what are the microbiologic criteria for diagnosis of a catheter-related bloodstream infection? So remember, how do you define a catheter-related bloodstream infection? You can have either culture of the same organism from both the catheter tip and at least one percutaneous blood culture, or culture of the same organism from at least 2 blood samples. And that can be one from a catheter and the second from the peripheral vein. Sometimes we can't draw peripheral blood cultures on patients, so you have to use the second lumen, right? So remember, the idea of 2 specimens is important, because obviously two specimens are less likely to reflect contamination from any one particular site than one specimen too. So remember those definitions. This is necessary to meet microbiologic criteria for the diagnosis of a catheter-related bloodstream infection.
Now that says tip, so that means you pull the catheter.
You're talking about,
First bullet.
yeah, from the catheter tip, exactly, and at least one percutaneous blood culture. Thanks for that distinction.
Do that initially.
That is correct, yeah. So
You want a blood culture from the catheter.
if you can,
Peripheral.
right, ideally you want to get a blood culture from the catheter and from a peripheral site. That's the ideal situation. If you can't get that, then perhaps if you can get them from different lumens, that's significant, because remember the lumens exit at different points along the side of the catheter. But ideally, if you can get a peripheral blood culture and a blood culture from the catheter, that's the ideal situation.
Just the other thing to quickly add, these are CRB is central line related bacteremia. Remember that they'll call them PIC midline, which is not really a central catheter. It only goes up a short distance into the arm. That is not a central line associated bloodstream infection. If it's associated with a PIC midline, it doesn't meet CDC criteria.
That's a good point.
Well, they'll call them, you'll see people write it as a PIC midline, but it's really not a PIC, it's a midline.
So what are some other considerations with this? And this is a little complicated. I apologize for that, but there are different ways to think about assessing catheter-related bloodstream infections. The definition of quantitative blood cultures, that's when your lab does colony counts, and the colony count from the sample that you've obtained from the catheter hub is greater than or equal to 3-fold higher than the colony count from the peripheral vein sample. That's diagnostic of a catheter-related bloodstream infection. When semi-quantitative blood cultures, the definition of that is you have more than 15 colony-forming units of the same microbe from the insertion site, the hub site, and a peripheral blood sample. That also supports the diagnosis. Now, the problem with these is a lot of times your lab won't do these first two. So, in contradistinction, a lot of labs can do what's called differential time to positivity, or DTP. This is when you detect growth from the catheter hub sample at least 2 hours before growth from a peripheral blood sample. And that has very high sensitivity and specificity. And so there's a lot of argument that if you're going to ask your laboratory, your microlab, to do one of these, the easiest for them to do is the differential time to positivity. Even if they don't officially do it, you may be able to call them and say and this assumes that your blood cultures are labeled, because that's key, to label your blood cultures. If you don't label your blood cultures, how are you going to know a differential time to positivity or the first two, the quantitative or semi-quantitative? But if they label them, you can ask your lab, well, I see here that these cultures were obtained from the catheter. When were they called positive, and when were the peripheral ones called positive? If it's more than 2 hours, then that meets the criteria. Any comments from you guys about that? No?
You'll have to figure it out here. The only thing that gets any kind of semi-quantitative is catheter tip cultures, which almost every lab's done because we've been taught that for years. You're going to have to calculate the differential time. And sometimes that thing is true. It all takes is to call down the micro. When did it get put in the machine? And then they'll tell you it's reported out when it was positive. Because anything that kicks the blood culture to positivity, then they immediately gram stain it. So if it's 24 hours that you have a positive blood culture, probably significant. If it takes 3 to 4 days for something to grow, that's probably, there's a very small inoculum that got in that bottle. It's taken that long for it to really kick the machine to say it's positive. Those tend to be, not always, but they tend to be more of a contaminant. But yeah, this has been the biggest controversial thing, I think, recently, is the time to positivity. And does that absolutely mean you have to pull the catheter? The answer is not necessarily. But it must still be fun.
Yeah.
About the semi-quantitative cultures from the tip, is there a mention about the sonication or flow plate or something? Because I remember there's a...
Yeah, I think I'm going to talk about that in just a minute here. So, now what about a single positive blood culture for coagulase negative staph? Okay, what about that? So we know that that's usually a contaminant. It's usually a good idea to repeat the blood cultures, and if you're going to obtain repeat blood cultures, you want to generally obtain repeat blood cultures through both the suspected catheter and a peripheral site if possible. Removal of a catheter just on this basis, very controversial. Most people won't do it. And you could always consider antibiotic lock therapy, which we'll talk a little bit more about in just a second. So, here's more about the diagnostic criteria as Dr. Noel was talking about. So how about catheter tip cultures? Should be performed upon catheter removal when infection suspected. Now for central lines, again, these are non-tunnel catheters. If less than 7 to 10 days old, extraluminal infection is more likely. So you can consider culturing the intradermal portion if they're early. Later on, intraluminal infection may be more likely, or infection of the catheter tip, and as a result, it's generally recommended send the catheter tip if it's an older catheter. If it's a younger catheter, again, the infection may be more likely to be in the intradermal portion. So now this is something I was less familiar with when I was putting this lecture together, but it's an interesting idea. How about tunnel catheters? You culture the tip at any age. It doesn't matter, because remember, extraluminal infection in tunnel catheters is less likely because you have that long tunnel and you have barriers to extraluminal infection. So here's the diagnostic criteria. So if you have for semi-quantitative cultures, a semi-quantitative broth culture growth of greater than 15 CFUs from a 5-centimeter segment of the cath tip by roll plate culture. Or if you have a broth culture, a qualitative broth culture of greater than 10 to the 2 CFUs from a sonicated catheter. So those are the diagnostic criteria that the microbiology laboratory uses to define a catheter tip infection. You can also swab any drainage material. We've done that before. If you see a triple lumen, for example, and there's discharge from the catheter, it's acceptable to culture that. And do not treat positive cath tip cultures in the absence of bacteremia. Again, you want to demonstrate bacteremia. That's part of the criteria. So what about management considerations? When do you treat a catheter infection? When do you not treat? How do you manage the catheter device? And how about antimicrobial therapy? Which is better, parenteral versus antibiotic lock therapy, or both? Which antibiotics do you use? Do you modify therapy at any point? How long do you treat? And how do you address refractory or persistent cases? So, under indications for treatment, systemic therapy is not required. Again, if all you have is a positive cath tip culture, most of us would agree you don't treat that, right? How about positive blood cultures obtained through the catheter with negative cultures through a peripheral vein? Again, how do you know under those circumstances that you have a legitimate infection? All you have is a positive catheter, a positive blood culture from a catheter. That may represent colonization of the catheter and not true infection. That's why it's so important to label your blood cultures and to get cultures through the catheter and cultures from a peripheral vein. Phlebitis in the absence of infection, I think most of us would agree that you can treat that with other means. If it's a deep thrombosis, well, that can oftentimes be suspicious for infection. But in the absence of clinical signs, most people might treat that with removal of the catheter and perhaps anticoagulants, or maybe not. For superficial thromboses, again, warm, moist heat to the area, elevation, and so forth may resolve the condition. When do you remove a line? If you have somebody who's got severe sepsis, hemodynamic instability, evidence of a metastatic infection like endocarditis, evidence of suppurative thrombophlebitis with erythema or exudate, persistent bacteremia, and there are some organisms where you tend to want to pull the catheter. Staph aureus, most of us would agree. Enterococci, again, where the enterococci infection is felt to be the catheter and not some other site. Gram-negative bacilli, especially Pseudomonas, fungi like Candida, and mycobacteria. Again, it's agreed, mycobacteria, very difficult to eradicate from a implanted device. Most would agree that you would pull the catheter. How about Bacillus, Micrococcus, or Propionibacterium? Although they're low virulence, they're difficult to eradicate, and that's why you pull the catheter. Not because they're very virulent organisms, but they're hard to eradicate without removing the device. Propionibacterium, sometimes it can be contamination, but also difficult to eradicate. Do you have to remove a catheter in an FUO? a lot of times, obviously, if you identify another source and you're suspicious of another source, you can leave the catheter in. It's only when you have endovascular prosthetic material, for example, or if you're sure that it's the catheter, sometimes we'll say take the catheter out. Catheter salvage, again, there are certain organisms that you don't use with catheter salvage. There are others where you want to consider salvaging the catheter, particularly in a patient where line removal and replacement may be of high risk. And in those cases, the use of antibiotic lock therapy is strongly encouraged. When do you change over a guide wire? When you have to remove the catheter, there's no sepsis, and there's an increased risk of complications in putting a catheter in a new site, you can consider guide wire exchange. You want to culture the cath tip, and if that cath tip culture is positive, you strongly want to consider taking that catheter out and putting it in a new site. The benefit of antimicrobial impregnated catheters, as I've said, is controversial. Now, how about antimicrobial therapy? Obviously, you have those big four organisms, right? Staph aureus, coagulated staph, Enterococci, and Candida. So under the, obviously you want to cover for gram-positives. If the patient is at risk for Candida, you want to cover for Candida as well. And if the patient is at risk for gram-negatives and the risk of gram-negative endotoxemia is great, then you want to cover for gram-negatives, because gram-negative endotoxemia can kill a patient far faster than gram-positive bacteremia can. If a patient's colonized with drug-resistant organisms, if you have somebody who has had a history of stenotrophomonas or a Klebsiella pneumonia carbapenemase, for example, then you want to consider that, or Acinetobacter, you want to cover those organisms as well. Someone with TPN, prolonged broad-spectrum antibiotics, hematologic malignancy, and so forth, they may be at risk for candidemia, and those patients should be covered with antifungals. We're going to talk about organism-specific therapy, so I can answer your questions about specific types of infections. Coag-negative staph, we've seen, most common cause of catheter-related bloodstream infections, and oftentimes it can be difficult to distinguish whether it's a true pathogen or a contaminant. However, if you isolate coag-negative staph from multiple sites, that increases the likelihood it's a true infection. And there's a lot of controversy about whether you just remove the catheter. In some cases, that may be all that's necessary. Do you treat for 5 to 7 days after catheter removal? I think most people accept that shorter-term therapy for coag-negative staph in the setting of catheter removal is acceptable. Can you salvage the catheter with a 14-day or 10-day course of therapy? I think that's acceptable. How about if there's a negative TEE and there's endovascular hardware? Well, most of us acknowledge we could treat for longer in those cases. In some cases, a 3-week course of therapy may be acceptable. 6 weeks of IV antibiotics in the setting of endocarditis. I think most of us would acknowledge that is a good idea. Now, Staph aureus, of course, is probably the catheter-associated bloodstream pathogen that we take the most seriously, right? Has the potential for greatest morbidity, greatest distant foci complications. Most of us would acknowledge that it's mandatory to remove a catheter if there's Staph aureus bacteremia. When do you replace the catheter? The experts say if blood cultures are negative at 72 hours, it's okay to reimplant. It's important to remember that the duration of therapy is a guesstimate. There's not really any evidence-based medicine that says how long should you treat in the setting of an MRSA or a Staph aureus bacteremia. If someone has MSSA, most of us would acknowledge that vancomycin is not the best therapy, right? You want to consider nafcillin, oxacillin, in some cases daptomycin. Many cases of Staph aureus catheter-associated bloodstream infection can progress to endocarditis, and we need to keep that in mind, particularly when someone has multiple positive blood cultures, a previous history of endocarditis, or persistent bacteremia. Many of us would obtain a TEE when someone has Staph aureus bacteremia. And Staph aureus bacteremia is associated in many more cases with septic or hematogenous complications like discitis, for example, endocarditis. So we don't want to think about just the catheter. We want to think about the possibility there could be other distant infections accompanying the bacteremia as well. These are some risk factors for hematogenous complication. I won't repeat them, but you can see them there. And the treatment duration, as we've said, is not evidence-based. So there's a spectrum of treatment, and that can range from, let's say, 7 days if you have a positive catheter tip that grows Staph aureus and maybe not bacteremia. Some people would treat for 7 days, to as much as 6 weeks when we have someone with a complicated Staph aureus infection with septic complications. We generally want to discourage catheter replacement over a wire, and we've already said catheter salvage with Staph aureus because there's a high relapse rate, and we've already talked about the last point there. How about Enterococcus? So Enterococcus usually requires catheter removal and systemic antibiotic therapy if your suspicion is great that the bacteremia is coming from a catheter. Catheter removal is encouraged if there's insertion site or pocket infection, suppurative thrombophlebitis, obviously sepsis, endocarditis, persistent bacteremia, or metastatic infection. Ampicillin is the antibiotic of choice, vanco of penicillin allergy, and alternatives particularly for Enterococcus faecium, obviously linezolid and daptomycin. How long do you treat and when do you use combination therapy? It's less clear. Surprisingly, there's a greater risk for endocarditis with Enterococcus faecalis than with faecium. And if you have somebody with an uncomplicated catheter-related bloodstream infection, again, the range of therapy, 7 to 14 days. Someone with a complicated infection, obviously up to 6 weeks. How about gram-negative rods? If you suspect gram-negative rods, again, you're talking about the potential for gram-negative endotoxemia, which can, as I've said, have high mortality. So those are cases where you want to cover a patient, at least initially. What are some treatment issues? Do you treat patients with broad-spectrum therapy if they are at risk for MDR infections? When do you treat with combination therapy versus a single agent? How long do you treat? Generally 7 to 14 days. How about Candida? We've already said removal of a catheter is advised. Most people would use an echinocandin initially unless they were certain that a patient had always grown C. albicans and they could use high-dose fluconazole. And we often acknowledge that we want to de-escalate to an azole if we can, like fluconazole, to complete their therapeutic course. In the case of Corynebacterium, Bacillus, or Micrococcus, true bloodstream infection usually requires more than one positive culture. Eradication usually requires catheter removal, and most people would treat with vancomycin. How about other issues to consider with catheter-related infections? Catheter colonization. If we document a single positive blood culture from a catheter hub, what does that mean? Is that a catheter-related infection? Is it colonization? Well, if it's colonization, keep in mind that that could progress to infection. So we need to heighten our surveillance in those cases, and maybe even consider antibiotic lock therapy to eradicate the colonization. And treatment duration, again, I think I've covered on the preceding slides. Now, how about antibiotic lock therapy? We have a patient on our service right now here at the VA that we're using antibiotic lock therapy. What are some considerations? Well, the whole concept of antibiotic lock therapy is that you're exposing the catheter lumen. Remember, not the external part of the catheter, but the catheter lumen, to high enough concentrations of antimicrobials that you can kill the organisms within a biofilm. Now, although this is useful for lower virulence organisms such as coagulase negative staph or gram-negative bacilli, it's not usually something we use for higher virulence organisms like, for example, obviously Candida or Staph aureus. Those patients we usually remove the catheter. the duration of therapy is usually concordant with how long we're treating the patient with systemic antibiotics. So if we're treating the patient with systemic antibiotics for 2 weeks, for example, it's okay to just continue the lock therapy until your systemic antibiotic therapy is completed. And as we've said, it's usually not used if there's Staph aureus, Pseudomonas, drug-resistant gram-negative bacilli, or Candida. Now, is antibiotic lock therapy always good? What's the downside? I always like to think of the downside because, you know, we have to think about collateral damage. Anytime we use antibiotic therapy, we have to think about the downside of antibiotics. Well, in some cases, antibiotic lock therapy has resulted in fungal superinfection because, remember, those are systemically low concentrations of antibiotics. Does this increase the likely risk of Candida, for example, particularly in the case of Enterococcus, where it's been associated? Is there an issue of systemic toxicities of antibiotics or anticoagulants in lock solutions? We were dealing with an issue with our patient where maybe the antibiotic lock therapy wasn't being administered appropriately, and the patient may have been subjected to lower than therapeutic concentrations of these antibiotics systemically. Does that induce antibiotic resistance? There was also a reported case of sensory neural hearing loss with someone who was on antibiotic lock therapy with amikacin. So we always have to consider those possibilities. And as a result, antibiotic lock therapy is something that should be closely monitored for complications, and proper administration is advised. And if you don't properly administer, it's not going to be effective, and you're going to increase the possibility that these other things can occur. Now, what are some other issues with catheter-related infections? How about local site infections? Now remember, when you talk about local site infections, particularly with tunneled catheters, there's a difference between the insertion site and the exit site. Now, how many of you have witnessed a tunneled catheter being implanted? Some of you have. So you know that tunneled catheters, they initially implant them at the insertion site, and then they tunnel them to what's known as an exit site. So those are actually different. And if you look at a Hickman catheter site, if you look at a freshly implanted Hickman catheter, you can usually point out where the insertion site is and where the exit site is. Those are different. So if you have an insertion site infection, that's especially in a newly implanted tunnel catheter, that's considered somewhat more serious because, remember, that's in closer proximity to where the site of the catheter goes into the vessel, and that should usually prompt catheter removal to a new site. Generally, you want to culture that site, culture the catheter tip, and obtain blood cultures from a peripheral site to see if that's more of a systemic infection. And if blood cultures are negative, however, usually you can get away with shorter therapy, usually less than a week. For exit site infections, because those are I'm thinking of the proper terminology, they're more distal from the patient's intravascular bloodstream to the tunnel, then usually you can treat those with topical antibiotic agents unless the blood cultures are positive. If the topical antibiotic therapy doesn't work, then you may need systemic antibiotics. But if the systemic antibiotics don't work in the setting of an exit site infection, you usually need to pull the catheter. Now, how about tunneled infections? I think I have a picture here of a lady with a female patient with a implanted, this looks like a Hickman catheter, a triple lumen, maybe a dialysis catheter as well. Hard to tell. But you can see a little bit of erythema there right after the exit site of the catheter. And that could be a tunneled site infection. Now, sometimes these can be very much more significant, and patients can have intense pain and swelling and fluctuance along that tunnel site. Those are the very purulent infections where sometimes you can actually milk out the pus from the exit site and take a culture. So sometimes the local signs and symptoms can be subtle, like in neutropenic patients who may not manifest major response. Sometimes you can just use systemic antibiotic therapy. Some cases may require catheter removal, particularly with Staph aureus or more virulent organisms. Sometimes it can be so significant that you may even require an IND of the tunnel catheter site. Uncomplicated thrombophlebitis warm soaks and elevation. Septic thrombophlebitis may require catheter removal and IV antibiotic therapy. All right, so we're getting near the end here. So how about prevention? Very important as well, because if you prevent these infections, you can avoid a lot of morbidity and utilization of resources. So, first thing you want to do is choose an appropriate insertion site. As we've seen, the best and lowest risk place to place an implanted catheter is in the subclavian, right? If you have an IJ, sometimes patients can drip secretions down into their IJ site. It's a less protected area. It's hard to put dressings there. They come off. And everyone will acknowledge that femoral sites are the worst, right? Highly likely to be contaminated, hard to care. There's a lot of hair in those areas. You may need to shave the site to get. It's not the best solution. Barrier precautions during insertion. Experienced inserters. It's not known whether coated catheters are better. Daily inspection is crucial, and changing dressings regularly, and patient education. But for us here in the room, removing catheters when no longer needed. That should be our focus. As soon as a catheter is no longer needed, it should be removed. That's the way to prevent complications. And particularly, infection risk increases with time by the device. For peripheral catheters, even midlines, or even peripheral IVs, greater than 3 to 4 days, the risk is higher. CVLs, usually greater than 6 days. A cordis, for example, greater than 3 to 4 days. An art line, 4 to 6 days. PICC lines and tunnel catheters obviously are designed to stay in a lot longer. So, the central line bundle is an essential component. These are 5 evidence-based components that are critical and are identified by hospitals to reduce the risk of central line associated infections. And just to mention, to close with these, hand hygiene, maximum barrier precautions, chlorhexidine skin antisepsis for catheters, optimum catheter selection, and daily review of the necessity of a line. These have been identified as critical to reducing infections. Do you all want to add anything to this?
Barriers for both the patient and the listed. I think you covered it really well.
All right, so you all should now know how to manage every catheter-related bloodstream infection. So go out there and take good care of your patients, and I hope I've covered this adequately for anyone, but I'll be happy to take any questions.